you tell people, let's say someone who had a history of melanoma, right, and family history of melanoma, they ask you this question: do I need genetic testing? And maybe we can touch that a little bit upon that. Like, one is, what criteria do you set to refer a patient to a genetics consult for genetic testing?
And you're talking germline genetic testing now, right?
Yeah.
Yeah. So there are some criteria, right? Because hereditary melanoma in the germline, right? It's usually hereditary. So the reason it's I talked about it being in the egg or the sperm. The reason it's there is because it came from the parent, right? So it's hereditary. So you inherit these mutations usually. And that doesn't mean it's always that case. Sometimes you can have a mutation that happens when you're in utero, right? At the time of conception or in utero, and it's not inherited, and you're the only one. So you have both situations. And so when we think about who is a good candidate for getting genetic testing, what I look at is I look at their personal history of melanoma, right? So if they have a personal history of melanoma that has 3 or more, if they've got 3 or more melanomas, primary melanomas, and then I start to think, that's a little too much.
Yeah.
It may be more than just sun exposure. It may be more than just bad luck. That may actually be that you've got. And so that anytime somebody has had 3 melanomas themselves, I always start the discussion about genetic testing. The other thing you want to look at is whether or not there's a pattern of inheritance, right? So you have to ask a family history. So you say, okay, are there any other people in your family? And of course, it has to be the bloodline relatives, right? It's not the in-laws. They don't count because they don't share genetics with you, right? It's only the ones that are actually blood related. But those, if you've got, again, my threshold is usually about 3, right? So for example, if I've got a patient who has a melanoma and it turns out that their brother had a melanoma and their mother had a melanoma, then that's 3. And that's enough to where, again, it crosses that threshold for me that I really think, okay, we need to start talking about genetic testing. But the other thing is, it's not only melanoma. There's some melanoma genes, some of the genes that predispose to melanoma when they have a variant in it. Some of those are associated with other cancers besides melanoma. And that's one of the reasons it's so important to ask a good family history, because, for example, I mentioned the CDKN2A mutation or P16 mutation. The people who carry those mutations, if they carry it, then they also have a high risk of pancreatic cancer. And you would never see a pancreatic cancer like you see a melanoma. So it makes screening those patients very important to make sure that you're catching it early before it's too late, because pancreatic cancer, again, is a very aggressive cancer. There's another gene called BAP1, and BAP1 also predisposes not only to melanoma in the skin, but it also predisposes to ophthalmologic, to ocular melanoma, and it predisposes to kidney cancer too. And so you want to be able to screen, and then maybe some other cancers too, but for sure we screen. We have them see an ophthalmologist as well. We have them see do a renal ultrasound, so we know that nothing's happening to the kidneys. And so when you're asking the history, if it crosses the level of 3 melanomas, for sure, but if you've got 2 melanomas and you have a pancreatic cancer as well, or if you have 1 melanoma and a pancreatic cancer and a neuroblastoma or something, or another kind of neurological tumor, that's 3. That counts as 3.
That's 3, meaning the personal, not just not bloodline relative.
No,
personal.
Even bloodline. So
Okay.
if my patient comes in and they've had a melanoma, and I say, do you guys have any other melanomas in the family? And they're like, no, we really don't have any other melanomas in the family. I'm the only one with the melanoma, but I've got 2 family members with pancreatic cancer.
Mm-hmm. You're
like, okay, you need to be tested for a CDKN2A and probably some other genes as well, right? And or they say, well, I've had because that's 3. But if you've had, okay, I've had melanoma and I had a grandmother and a mother that had breast cancer. Well, breast cancer is so common, right?
Yeah.
It's very, very common. Having a mother and a daughter have breast cancer, you might want to be tested for breast cancer, right? But it wouldn't necessarily make it melanoma. It's not a melanoma family. It might be a breast cancer family that you might want to check. But they start to add up, right? So if it's a common cancer like breast or prostate or colon cancer, I usually give them a half point. So like I want 3 points. That's what I want. I want to add up to 3 points to kind of give me a good enough probability, you know, and maybe that's something worth talking about too, is what do I consider to be a high enough probability of having a genetic cause to be worth testing, right?
So let me ask you another question. So couple of questions. One is, let's say someone who has 3 melanoma, does it make a difference someone who is 75 years old versus 45 years old?
It does. I think it does. It does for me. I mean, this is sort of an art, right? Because every human being is actually different. And so even though you can make some guidelines, you don't want to make them hard, fast rules, right? Because if a person, if you have a, let's say you've got a guy that comes in 75 years old, like you said, 75, he's been a river runner, he's got red hair, he's got sun exposure, and he gets a melanoma at 75 on his face that starts as a little lentigo maligna. The chances that even if he had 2 of them, or even if he had 2 and his brother who did exactly the same thing has 1 too, and you add up to 3, the chances that that's going to be because they're inheriting a mutation is much lower than if you have a person who's a 25-year-old who comes in. She's got a mole on her back that's turned into a melanoma, and she's got tons of funny looking moles on her back. And she's got a sister that has another melanoma and a family member that's maybe more distant that has pancreatic cancer. Okay, that's different. That one counts, even maybe at a younger age. You know, maybe you only have 2, but it seems really, really risky because they just aren't falling into the pattern of it being an environmentally induced melanoma, right?
Yeah. Also, I think another very important point you touched upon is that, you know, not all melanoma are the same, right? The lentigo malignant melanoma found on the face in elderly person, their biological behavior is totally different from, let's say, a melanoma on the back, right? And then this is mostly due to sun-induced, and the risk of the lentigo malignant melanoma spreading to the rest of the body, killing someone, is very, very low. It's just, that's why also this genetic component plays a role. And coming back to, you mentioned breast cancer. How does a BRCA gene have any, does the BRCA gene have, you mentioned BAP1, but what about the BRCA2 or BRCA1?
Yeah, the BRCA1 and 2, right?
Yeah.
And some people feel like maybe both of the breast cancer genes are associated with melanoma a little bit. Some people think, oh no, it's just the BRCA2. Some people say, oh no, it's just an association that's unrelated to a direct cause. And so there's a lot of controversy out there actually about how strong of a melanoma effect a BRCA gene has. So I don't think that we have a hard, fast answer on that yet. I do think, though, that sometimes in BRCA2 families, I've had several BRCA2 families who, you know, carriers have developed melanoma.
Yep.
You know, that happens.
Yep.
And it's not necessarily, I think there may be a susceptibility, right? So maybe there is a susceptibility, but it's not a high penetrance, what they call high penetrance, where if you inherit that gene, then your chances of getting a melanoma is about, you know, like with P16, for example, if you inherit a P16 mutation and you live in an environment in, say, the United States, your chances of getting a melanoma in your lifetime by age 82 is about 75%.
That's pretty high. That's pretty
That's
high.
high. They call
Yep.
that a high penetrance gene, right?
Yeah.
Now, if you have just red hair, right? You've got a red hair gene that we talked about, right? And you inherit 2 of them and you've got both of them. And by the time you're 82, you know, your chances of getting a melanoma is not 75%, right? But it's not 0. It's not, you know, it's higher. It's about 4 times higher than the average population, which would probably end up being about between 4 and 8%, right? That's a lot lower, but yet it's considered a low to moderate penetrance gene, right? But then when you put the 2, if you were to stack the 2 on top of each other, the chances that you're going to get a melanoma goes way up, over 90%, you know, if you've got both a P16 and an MC1R. So everything has to be taken, I guess, hopefully what I'm conveying is that everything has to be taken in context. We have sort of these general ideas about how detrimental the gene is, what organs it affects, and what other kinds of relationships it has with other diseases, right? But each person has to be considered an individual, really. You have to do it that way because there's so much variability from human being to human being, and everybody deserves that. They deserve a consultation with a genetic counselor that talks to them about all of the different elements of risk and what answering that question of the genetic background is going to tell them and why it's important, right?
You know, this is, I mean, again, thank you for providing such a rich context with so much information. You know, we touched about penetrance, multiple genes, play interaction between environment, you know, all this information.